Good morning. My name is Marie Rienzo, and I want to welcome you to the NIH Office of Disease Prevention's Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar by clicking on the question mark in the WebEx toolbar. Please direct your questions to all panelists. We will open the floor to questions that have been submitted via WebEx at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 1 week. You will receive an email when they are available. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be prompted to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Marie. Today's speaker is Dr. Jeffrey Sparks. Dr. Sparks is an Assistant Professor of Medicine and Associate Physician at Brigham and Women's Hospital and Harvard Medical School. His research focuses on using patient-oriented and epidemiologic methods to evaluate the etiology, outcomes, and public health burden of rheumatoid arthritis. In particular, he performs studies to evaluate genetic, environmental, serologic, and familial risk factors for rheumatoid arthritis, clinical trials for its prevention, and rheumatoid arthritis outcomes research focusing on the respiratory, metabolic, cardiovascular, and mortality burden of this disease. He has served as the chair of the American College of Rheumatology's Early Career Investigators Subcommittee with a focus on equipping trainees and junior faculty with the skills needed to succeed in research. He has received research awards from the National Institutes of Health, the Rheumatology Research Foundation, and the Brigham Research Institute. It's my pleasure today to welcome Dr. Jeffrey Sparks.
All right, thank you so much, Dr. Murray, and I'd of course like to thank the NIH Office of Disease Prevention for inviting me and for everyone who's listening in. I will mention that I am a practicing rheumatologist, but most of my time is spent performing patient-oriented and epidemiologic research, so I'm excited to share what we've done. So here's a slide about disclosures and funding. There are no personal financial disclosures. And of course, I'd like to thank the NIH, in particular NIAMS, for being interested in my research. This is funded by K23, R03, as well as the Loan Repayment Program. And I'll also thank the Rheumatology Research Foundation and the Brigham Research Institute for funding me. I'm always interested in feedback, so feel free to email me or tweet me at Jeff Sparks, as you can see on the top right. So here's the outline for what I'll cover today, and I'll mention at the outset I'm hoping to leave at least 15 to 20 minutes for a discussion, and I really look forward to hearing your feedback. Given that I'm not sure who's listening and whether you have a clinical background, I do want to make sure that everyone has at least a basis to understand the importance of this research area, so I'll spend just a little bit talking about the clinical background related to RA development. And most of what I'll spend is talking about my own research studies and really different types of research studies to interrogate an overarching hypothesis. So we'll talk about prospective cohort studies, nested case control studies, matched cohort studies, and finally a prospective RA registry where all of these we're trying to investigate the respiratory burden of RA. And finally, I'll end with an ongoing RA prevention randomized controlled trial. So first, I'll talk about the clinical background for the development of rheumatoid arthritis. So as many of you probably know, and as the name implies, this is a chronic inflammatory autoimmune disease that's characterized by painful, swollen joints. The joints that are typically affected are the small joints of the hands, feet, wrists, but really almost any joint can be affected. I think particularly interesting about rheumatoid arthritis is that this is the most common systemic rheumatic disease. It affects nearly 1% of adults, which is over 2 million adults in the United States. and 75% of patients with RA are women. The median age of diagnosis is 55 years, but really this can span the entire lifespan. Kids can get this as well as the very elderly. And despite just the joint involvement, there are many long-term consequences, including joint destruction, chronic pain, disability. And this is really a systemic inflammatory disease, so it does not just affect the joints. It affects really the entire body. Of course, every disease has some heterogeneity, and in particular, within rheumatoid arthritis, we often talk about autoantibodies. So there's two antibodies that are particularly common in rheumatoid arthritis: rheumatoid factor, RF, or anti-citrullinated protein antibodies, which are abbreviated as ACPA. So whether you have these antibodies or not kind of distinguishes you between subtypes of seropositive RA, which is the most common type with about 65% of patients. These patients have a more severe clinical course and they probably have a more homogeneous genetic background. Seronegative RA means that both of the rheumatoid factor and ACPA are negative. And this one's thought to be a bit more heterogeneous and maybe related to a variety of underlying etiologies. So the seropositive RA is more severe, but also more homogeneous. The other important thing is that there are classification criteria that have been defined to help us as researchers to really make sure that we're defining RA similarly across the board. So the classification criteria are very important to make sure that the patients we're studying are truly generalizable across studies. So as I mentioned, RA is a systemic disease, does not just affect the joints. And based on my research interest, I'm going to talk mostly about the lung, but at the outside, I'll mention that the RA can also affect the cardiovascular system and other organ systems. And that kind of makes RA particularly interesting to study because it's a pretty common autoimmune disease and it has really systemic effects. So it can help understand sort of long-term consequences of inflammation on the body. But RA and lung disease has long been known to be a consequence of RA, and in particular, there's this, some patients develop what's called RA-ILD, which stands for RA-associated interstitial lung disease. And similar to inflammation in the joints, this is characterized by pulmonary inflammation and or fibrosis. And severe RA-ILD affects about 2 to 10% of RA patients. However, subclinical or mild forms might affect 25% or more. These patients might have imaging abnormalities without overt clinical signs, and it's unclear whether some of those patients may progress to sort of more overt clinically severe RA-ILD. Known risk factors are male sex, older age, and seropositivity, and this can actually occur prior to patients developing articular involvement. There's also a known RA manifestation called bronchiectasis, which is really more focused on damaging the bronchi and airways. These patients can have shortness of breath and cough, and can be at increased risk for pneumonia. And this is thought to be a relatively rare manifestation, typically of long-standing severe seropositive RA. So I'm going to talk about the model of seropositive RA pathogenesis here. And really, this is sort of a progression through a life course about how someone might develop rheumatoid arthritis and its consequences. I mentioned at the outset that, again, I'm focused on the lung, just so we have a limited scope for this talk. But there may be other mucosal sites that RA may develop at. But basically, people are obviously born with different genetics, and some of those genetics do predispose people to rheumatoid arthritis, in particular, an immune set of genes called the HLA, shared epitope. And it's thought that throughout life, there might be a trigger for people who are genetically susceptible, and this may occur at mucosal surfaces. And certainly, the lungs are a susceptible mucosa. And it's thought that an environmental factor, in particular smoking, might induce inflammation in the lung mucosa. And actually what could be happening on the molecular level is that amino acids are, particularly arginine residues, are citrulinated through an enzyme called peptidyl arginine deaminase to form neoantigens. And the antigen-presenting cells actually present these neoantigens to T cells through the DRB1 receptor. And these T cells then activate B cells locally to produce rheumatoid factor and ACPA. And I'll mention this could actually occur many years prior to patients ever developing articular symptoms. And I'll show some data later about that. So these antibodies seem to be formed locally in respiratory mucosa prior to sort of more a systemic epitope spread. And at some point, immune tolerance loss and joint specificity is gained where patients finally are developing symptoms here. And certainly at some point come to their doctor to clinical attention with more clinical RA and widespread inflammation in the joints. And again, some patients might go on to develop clinical pulmonary diseases. And really the prototype here is related to smoking and how this might forward this biologic processes. I mentioned before that sometimes this inflammation in the lungs could occur even before the articular onset. And I'll show you that some of our studies are trying to interrogate this hypothesis. So this is really the only background I'm going to talk about. And I'll mention there's many other investigators who have helped fill in a lot of these research gaps, and I'll focus on my own research from here on out. So now I'm going to talk about prospective cohort studies for incident RA risk. And I'm going to describe the data sets here, which may be familiar to some of you. Some of our studies are performed in the Nurses' Health Studies. There are actually two cohorts. The first one, which was NIH funded, was the Nurses' Health Study, which was started in 1976, where they enrolled 121,700 nurses who were aged 30 to 55 years in 1976. So this is a closed cohort. Once you're in the study in 1976, you can't, it's not a rolling enrollment. And this has really been, as many of you know, a fantastic resource for many researchers. These women have been phenotyped for many branches of medicine. Obviously, our group is particularly interested in rheumatoid arthritis. But the study itself is really based on questionnaires where every 2 years, these women are sent questionnaires and they have quite high follow-up. And the data that are collected include things like smoking, body mass index, physical activity, diet, medications, diseases, income, as well as some other variables. And what we do is we actually identify incident rheumatoid arthritis that occurs after baseline. And I'll go over the research methods for this later, but we've actually identified up to over 1,100 brand new RA cases that occurred after the baseline in 1976. And while the last point here is 2014, the study's actually still ongoing, so it's been going on for over 40 years. Luckily for us, there's actually a Nurses' Health Study 2, which is very similarly designed with a similar sample size, about 116,000 women. Some subtle differences that the women were slightly younger, 25 to 42 years, and similar to the Nurses' Health Study 1, these were enrolled in all in 1989. And again, we've identified incident RA cases. So they're a little younger, we have a little less follow-up, so we have about 600 RA cases that have been identified, but basically quite similar data collected, again, by questionnaire. So some of our analyses, we can analyze the cohort separately. Some of them we pool them, some of them we meta-analyze. So it's obviously a great resource to have nearly 250,000 women that with these great follow-up data. The other nice thing about the Nurses' Health Study is that they actually donated blood in each cohort. So the blood was donated around 1989 in Nurses' Health Study 1 and around 1997 in Nurses' Health Study 2. So you can see already that we're able to sort of construct a timeline of RA related to when the women entered into the cohort and when all the research measures were gathered, when the blood was banked, and when the RA was diagnosed and identified. So again, about 1,700 RA cases. I want to go into more detail about how we identify incident RA in both of these cohorts. So on the questionnaires, there are questions about new diagnoses of many chronic diseases. We're interested in rheumatic diseases, and for this study, we'll talk about rheumatoid arthritis. So basically, the nurse has to report a new diagnosis of rheumatoid arthritis, and then we mail a screening questionnaire that was previously validated to see whether it's worth getting their medical records, and the screening questionnaire has about 100% sensitivity. So for those that screen positive, we then obtain their actual medical records. We actually mail the nurse and get informed consent to talk to their doctor. And then once the medical records are requested and obtained, 2 board-certified rheumatologists review each record independently and we actually collect the research classification criteria so that every RA case meets the ACR-EULAR criteria. The other important things are that we're able to collect data on rheumatoid factor and ACPA, so we're able to see whether these patients are seropositive or seronegative. We're also able to understand when symptoms occurred, when the clinical diagnosis occurred, so that this can help us, again, construct this timeline for RA pathogenesis. So the first type of study I'll talk about in the nurses' health studies are a prospective cohort study design. So I have a schematic here to sort of walk you through how these studies occur. So as I've already mentioned, the Nurses Health Study 1 starts in 1976. And certainly RA can occur anytime through life, even before 1976. So we've tracked down these medical records and classified these women as having rheumatoid arthritis and when the date of onset was. So certainly when we're talking about exposures predicting rheumatoid arthritis, we want them to be free of rheumatoid arthritis and to have that exposure measured at baseline. So for instance, this participant who had prevalent RA is certainly not at risk of developing RA, so would not be part of our study sample when we're analyzing for incident RA risk. We then calculate person time by exposure status for both eligible cases and non-cases. So basically, we're looking to see whether this future RA case, whether they were exposed or not exposed to whatever variable we're interested in, and we sort of tally up the person time to see whether that exposure status puts you at more risk of rheumatoid arthritis. Similarly, for people who do not become a case, we're really tallying their exposure status to see where the sort of incident risk can come from. And the other nice thing about the data set is that many important confounders are also concurrently, and there's also data every 2 years, so we're able to sort of do time-updated exposure status for things that might have changed with time. So I'm going to give you an example of one of our analyses now that's related to the importance of our pathogenesis of RA. So this is a study looking at smoking and rheumatoid arthritis. So in this study, we had a study sample of over 230,000 women that were pooled in both cohorts, and we identified over 1,500 incident RA cases and over 6 million person years of person time. So each woman had a mean follow-up of over 26 years per subject. So you can see why this is a really fantastic data set to be doing these analyses. Most of the cases were seropositive, so 969, and relatively less were seronegative. But again, we're able to try to understand whether exposures are particularly related to seropositive risk or seronegative RA risk. So the first study we did was looking really at just smoking status in a time-varying nature to see whether this is associated with RA risk. And so again, throughout the whole follow-up, we would categorize women as being never smokers, past smokers, or current smokers. And then we tallied up how many cases were in each exposure status, how many person years, and then we did Cox models to estimate hazard ratios and confidence intervals to see whether these were significantly associated with rheumatoid arthritis risk. Here we're looking at the subtypes of seropositive RA or seronegative RA. And again, we have data about particular confounders that I've listed here in the bottom: socioeconomic status, body mass index, physical activity, alcohol intake, oral contraceptives, etc. So we can see that these associations are independent of these or not. And you can see here that we do see an association of both current and past smoking with seropositive RA. And you actually see a bit of a stronger association of patients of current smokers compared to past smokers. And we see no association with seronegative RA. So again, the seropositive RA, smoking seems to be a risk factor, where seronegative RA, it might be a relatively different etiology for that subtype. So we again wondered whether actually a smoking behavior change of quitting smoking actually affected seropositive RA risk. So obviously, we'd rather not people smoke, but if they do quit smoking, how would this affect their downstream risk for seropositive RA? So we performed this analysis only among ever smokers, and we looked to see whether timing of smoking cessation affected seropositive RA risk. So on the x-axis are years since smoking cessation. On the y-axis is the hazard ratio for seropositive RA risk with the reference group as current smokers, and you can see that there's really a strong protective effect of quitting smoking, particularly sustained smoking cessation in seropositive RA risk. Conversely, when we look at seronegative RA risk, we really saw no association of cessation with seronegative RA risk, again arguing that both smoking and smoking cessation are probably quite important only for the seropositive RA subtype. So we then ask, well, we know that smokers are associated with rheumatoid arthritis risk. What about a disease that is particularly smoking related? So this is recent work where we analyzed whether chronic obstructive pulmonary disease was associated with RA risk. And COPD, as many of you might know, is really thought to be highly related to smoking. And often have a lot of structural damage to their airways, which might be a nidus for producing the rheumatoid factor and ACPA. So in this study, similar to the last one, and luckily the Nurses' Health Study also phenotyped each woman for whether they had COPD or whether they had asthma or not. And we looked to see whether COPD puts you at risk for future RA risk. And you can see that there's a pretty strong association of COPD with RA with a hazard ratio of 1.8. And really this risk is only in the seropositive RA subgroup. And because smoking is so related to both COPD and RA, we had to particularly think about adjusting for smoking. So luckily we had smoking pack years and we adjusted for both continuous and quadratic terms of smoking as well as their smoking status as well as the passive smoking status. We then performed a sub-analysis where we restricted the analysis to only those that were smokers and only those that were aged over 55, given that that's a typical demographic for COPD. And we actually saw a particularly strong risk of this subgroup of COPD with seropositive RA. And again, really finely adjusting for many types of inhalant and smoking exposures with a hazard ratio of nearly threefold for smokers that were aged over 55 for seropositive RA risk. And again, no association with seronegative RA risk. So what this tells us is that, really smoking and lung inflammation seem to be highly suggestive that women might develop rheumatoid arthritis in the future. Certainly these are all associations, they're not causal. But from a study design perspective, these were all prospectively collected data. We've adjudicated all the outcomes. The exposure status have all been validated. So we feel like these are strong study designs for this type of observational research. So now I'm going to switch gears a bit. I'm going to still talk about the Nurses' Health Studies, but talk about nested case control studies. In particular, as I mentioned, there were blood that was donated for research purposes in the Nurses' Health Studies. So we're able to look at biomarkers to see whether that predicts future risk of incident RA. So I'll walk through the study design here. Again, all throughout the cohort, women might have developed RA, and we do know that they meet our case status. And a subset had blood draw in 1989. And so we really need the cases to have both RA diagnosis and bank blood. So this woman who did not donate blood is not in our analyses. We then match each case to controls with the matching factors of age, menopausal status, and postmenopausal hormone use. But the important thing is that the blood is always before the case status. So we're really looking at circulating factors in the blood and future risk of rheumatoid arthritis. And in particular, we're interested in this ACPA antibody, sometimes called CCP, to see whether and when that occurs before rheumatoid arthritis. So this is one of our earlier studies to look at the ACPA titers to see when they start rising. You can see that they really start rising at least 7 years prior to a clinical RA diagnosis. And this tells us that there's a window of opportunity where these patients have circulating ACPA prior to articular onset. And so these patients are at particularly high risk of developing rheumatoid arthritis. So we've done quite a few studies related to biomarkers and future RA risk. I wanted to highlight a recent study we did related to this paradigm of mucosal inflammation. And we basically wanted to look to see whether having an airway disease such as asthma, where airway inflammation is sort of part and parcel, to see whether those women were more likely to have ACPA in their blood prior to RA diagnosis. So we really phenotyped the RA cases as either having or not having ACPA in their blood prior to RA. And you can see that there were 96 outcomes that were pre-RA ACPA positive prior to RA diagnosis, and that women who had asthma at that time point of blood draw were nearly 4 times more likely to have ACPA in their blood compared to those without asthma. Conversely, women that had no ACPA in their pre-RA blood, asthma had no association. So we're also able to sort of look forward. That one was more of a case control study, kind of a binary yes/no. This study is looking to see whether we can look at outcomes before and after RA diagnosis. So again, we're able to construct a timeline of RA, and in this study, we're really focusing on those that have the blood draw measures, and we're looking at the index data blood draw and looking in the future, and we can, again, all these patients have RA after the blood draw date, and we were really interested to see whether pre-RA cases based on ACPA status were more likely to develop lung diseases, in particular COPD. And we also have these covariates for adjustment, including smoking, and we would, have a good outcome variable of incident COPD. So in this study, again, we're really doing a matched cohort study within the Nurses' Health Study to look to see after the blood draw whether women are more or less likely to develop incident COPD. And you can see here that compared to controls, those with ACPA, this has about 16,000 person years, that those who had pre-RA ACPA in their blood prior to RA were 3-fold more likely to develop incident COPD than those than matched controls. Conversely, if you did not have the ACPA in your blood, you had very similar risk for COPD. And again, we're able to adjust very finely for smoking and other potential covariates that could explain the relationship. So I'll move back to the main cohort, not just focusing on the blood cohort, to look at another type of matched prospective cohort study design, where we're really trying to basically form an incident RA cohort within the Nurses' Health Studies as a large. So I've already told you the framework of the Nurses' Health Study starting in 1976 with questionnaires every 2 years. And basically within the Nurses' Health Study 1, we've identified over 1,000 incident RA cases, and we've defined this as the index date. And we also were able to collect baseline characteristics for confounders, and we're really looking forward at this point after a clinical RA diagnosis for outcomes. The nice thing is that we're able to actually measure time-varying covariates after the index date, and because this is sort of in between the exposure and the outcome, you have to think about special statistical methods for this. So we've been using inverse probability weighting and marginal structural modeling to handle variables that might both confound and mediate this relationship. And then we construct a comparator cohort where we match each RA case to 10 non-RA comparators. So this cohort has over 10,000 women in it, and they have basically the exact same measures. They have their own index date, their own baseline characteristics, their own follow-up for outcomes, as well as their own time-varying covariates. So in this sense, we're able to actually compare RA to sort of the counterfactual, which would be this comparator cohort, to see what would have happened if these women didn't get RA, or what is the disease causing as sort of downstream effects. So again, we were interested in lung diseases, and we're particularly interested to see whether these women were more likely to develop COPD. And again, the 3 phenotypes, all RA, seropositive RA, and seronegative RA. And this is adjusting for the sort of time-varying nature of smoking both before and after the index date. And you can see that all RA is associated with incident COPD, even adjusting for smoking as both a confounder and a mediator, and that this is particularly true in the seropositive RA sense. So what this tells us is that there's something about RA as a disease state that is putting women at risk of airway inflammation. We also looked at mortality, obviously a very important outcome. And it's probably not a surprise that RA as a chronic inflammatory disease does affect mortality. But we're particularly interested to see about respiratory mortality and whether this is related to smoking or some of the multimorbidities such as COPD that might occur. You can see here that, again, adjusting for these covariates, both as confounders and mediators, RA does seem to affect respiratory mortality quite dramatically. And in particular, this respiratory mortality risk is really confined to those who have seropositive RA. So seropositive RA compared to the comparators have a nearly threefold risk of respiratory mortality that was not explained by measured multimorbidities, including COPD and asthma, as well as lifestyle factors such as smoking. So what this really tells us is that there is quite a pronounced respiratory burden of rheumatoid arthritis, in particular for the seropositive RA patients. So that concludes the portion of my talk that's going to speak about the nurses' health studies, which, as you can see, has a lot of public health implications, but some of the things that patients and rheumatologists really care about are RA disease characteristics, which are not collected in a cohort like that. Luckily, our institute has an RA registry, which I've been involved with, and this is called BRASS, which stands for the Brigham and Women's Hospital Rheumatoid Arthritis Sequential Study. So this was started in around 2013 and has about 15 years of follow-up, and recruitment's still ongoing. So these patients, we recruited over 1,600 patients at this point. Some of these have short follow-up, but some of them have quite long follow-up. They actually get measures every 6 months, and the types of variables in these analyses are things that are really disease-specific, whether patients have tender swollen joints, which kind of joints, what their blood inflammatory markers are. We actually, bank blood to test for autoantibodies, testing x-rays, so a lot more rich data about clinical variables here. For this analysis that I'll talk about in particular, I want to talk about a predictor called DAS28, which stands for the Disease Activity Score of 28 joints, the 28 joints being in the hands, wrists, elbows, shoulders, and knees, to see whether those are inflamed, and to see whether this affects that outcome that I mentioned earlier about rheumatoid arthritis-associated interstitial lung disease. And again, we do have a time-varying exposures of these the exposure as well as covariates. So I wanted to talk a bit about phenotyping, which obviously is the really important thing for research purposes. So RA-ILD and BRASS, we basically do a research review of all clinically indicated CT chest scans. So every CT chest scan is reviewed for research purposes by a pulmonologist and 2 chest radiologists. And we basically classify each CT scan as either uninterpretable, for instance, if they had lung cancer or active pneumonia, or no RA-ILD, early RA-ILD, or clinically significant ILD. And our outcome definition in this analysis was both the early and clinically significant RA-ILD, of which there were 86 incident cases. And the date of outcome was the CT chest scan that was first performed. So to walk through this study design, this is, again, another prospective cohort where we have a time-updated variable of the DAS28. I'm just going to give an example of someone that has 7 years of follow-up. These patients also have clinical care, so we also have access to their medical records to see, when and why and how the RA-ILD was diagnosed and treated. For this analysis, the end of follow-up was in 2016, and basically, again, we phenotype all the chest CT scans to see whether they have RA-ILD or not. Our study sample was to see whether they had the validated disease activity measure. And we had about 1,400 patients, and we're really looking to see whether the disease activity predicts RA-ILD. So this one's looking at baseline DAS28 to see whether it predicts RA-ILD within the next year, and then really updating the analysis for how the DAS28 might change with time to see whether this is related to RA-ILD risk. And of course, if their disease activity score goes missing, we drop those from the analysis because we're not sure how to tie the exposure to the outcome variable. So these are the results. And I'll mention that DAS28 is a really useful measure because this is how rheumatologists treat patients. We really try to categorize their disease as either active or inactive, the active meaning moderate or high DAS28, inactive meaning in remission or low. And this is when you see a doctor, they're going to try to make a decision with the patient to see whether their disease is active or not, and try to intensify treatment if they determine it is. So you can see here that those who are in moderate or high disease activity actually have a twofold risk of RA-ILD, again, adjusting for the known RA-ILD risk factors. And we wanted to look in a little more granularity because this is a nice continuous variable where we can make it into more categories, break it into the 4: remission, low, moderate, or high. You can see here that there's a strong P per trend that as your disease activity is higher, your risk of future RA-ILD goes up with almost a 4-fold increased risk in the high group. And then looking at a continuous variable for every unit increase in the DAS28, there's a 35% increased risk for RA-ILD. We've done a series of cohort analyses. I've just illustrated one here about RA-ILD. Some other ones we've looked at are dyspnea, pulmonary function test abnormalities, and other abnormalities on chest CT. But one thing you might have realized is that the chest CT was not done randomly. Some provider had some suspicion or wanted to do the chest CT for clinical purposes. So we're doing another study, which is a prospective sub-study where it's called BRASS-ILD, where people are really getting respiratory measures for research purposes. These would be PFTs, chest CT scans, 6-minute walk tests, and also getting blood and surveys related to lungs. And we just finished enrollment. We had 134 subjects enrolled, and we're actually doing these measures both at baseline as well as 2 years of follow-up. These patients are also enrolled within BRASS, so we're able to link the data that was collected for research purposes from the parent cohort with our prospective sub-study. So we're still analyzing these data. The first manuscript is submitted, so these are interim findings, but we analyzed the first 106 patients who enrolled. And really strikingly, and again, I think kind of goes back to the clinical observation, that there was a really high proportion of undiagnosed parenchymal lung disease. The 3 things we're thinking about here would be emphysema, which is related to COPD and airways disease, bronchiectasis, as well as the subclinical RA-ILD. And you can see that all 3 of these parenchymal lung diseases occurred in a pretty high proportion of these patients that didn't have a known diagnosis. So lumping them all together as parenchymal lung disease, we found that older age, white race, cough, pulmonary function test abnormalities, dyspnea, and then these antibodies, the rheumatoid factor and ACPA, were particularly related to undiagnosed parenchymal lung disease. So this is a real problem in patients with rheumatoid arthritis, and it seems to still be there in patients that in this era where there's better treatment. So I'll end very briefly on an RA prevention randomized controlled trial. We've kind of surveyed through many different types of observational study designs. I think there's a lot of strengths in those and some inherent limitations, but obviously the RCT is still going to be the gold standard related to trying to understand a causal interpretation. And as a bit of a background, I've already mentioned that the ACPA can be present in the blood for several years prior to clinical RA presentation. So this was a study that we recently did that was published just a few months ago, where we looked to see whether ACPA level predicted future risk of RA and whether among those that were positive, whether titer mattered. So those that had low ACPA positive, those that were just sort of borderline, their 5-year risk was 10%, but it really went up dramatically based on how high the titer was. So those at medium positive titer, 27%, and those with high positive titer, meaning greater than 3 times upper limit of normal, nearly 50% of those patients went on to develop RA within 5 years. So that brings me to STOP RA, which stands for the Strategy to Prevent Rheumatoid Arthritis. I'll mention that this is funded by the Autoimmune Centers of Excellence through the NIAID. So we'll again thank NIH for their support. And really the STOP RA is trying to find people who are at risk of rheumatoid arthritis based on ACPA at least 2 times the upper limit of normal. Obviously they can't have RA at the time of enrollment or related diseases. And if a clinician is really already using an RA drug called a DMARD for these patients, they're not eligible as well. So we really want individuals who are at high risk of rheumatoid arthritis, and we're going to randomize them to a study drug, either hydroxychloroquine or placebo. And what we do is these patients or subjects are on study drug for the first year, and then we follow them off study drug for another 2 years. So it's a 3-year trial. We're currently enrolling. Hydroxychloroquine, as an aside, is thought to be the safest drug that you might use for rheumatoid arthritis. So as far as the safety risk profile, we felt that this was a drug that was amenable for prevention efforts. And there's also equipoise because these are drugs that clinicians actually would use and consider in this situation. So I wish we had results now. We're still recruiting, but we're very excited about this. And it's really the first RA prevention trial in the US. So it's a quite exciting nationwide multi-site study I'll mention. So other things we're looking at in our Stop RA study are to understand whether the treatment might affect changes in levels of rheumatoid factor active inflammatory markers. We want to immunophenotype peripheral blood mononuclear cells. We know that the immune system is quite important, obviously, in patients developing this. And then we want to do some clinical and epidemiologic studies. In a way, while it's a trial, we're also able to understand what happens on these people who are on the cusp of actually developing rheumatoid arthritis. And certainly I'd be very interested to understand how the lung course and symptoms are important in understanding who does and does not go on to develop overt rheumatoid arthritis during the trial. But these patients are also getting surveys on their lifestyle factors, their diet, medications, medical history, family history, symptoms. And we also want to understand, obviously important from a patient perspective, is where and how does pain start? Because not only can we stop the disease, but maybe we could make it a more mild disease and less painful. So I think a lot of the transition studies to look to see before and after those who do transition to RA will be quite important for this study. So I'll end there. So hopefully we'll have enough time for questions. So just to summarize what we talked about, really what we're trying to illustrate is how different study design can really investigate this respiratory burden of seropositive RA. I hope you understand now that there's this overarching hypothesis related to serostatus and respiratory burden, and you can see how these different study designs can help us inform how that might happen. So we talked about prospective cohort studies, and we found that smoking and COPD were associated particularly with incident seropositive RA. We used biomarker studies in pre-RA. We found that the ACPA was elevated 2 to 10 years prior to RA diagnosis, and that those with the ACPA in their blood prior to RA were strongly associated with both asthma and COPD. And then RA itself seems to increase risk for COPD and respiratory mortality, and this does not seem to be explained by smoking. And finally, RA disease features do put patients at risk for respiratory outcomes. Those with worsened articular disease have worsened risk for RA-ILD. And we're very excited about recruitment that's ongoing for the first RA prevention trial, which will help disentangle some of these findings. And of course, I'll end with all of my collaborators, in particular, Beth Carlson, who's the mentor in my K23 grant, Nancy Shattuck, who's the PI of BRASS, as well as Michael Weinblatt, and Tracy Doyle, who's been a close collaborator, a pulmonologist here at Brigham and Women's Hospital, and of course have to thank the funders, in particular NIH, for their interest in my research. And I'm happy to answer questions.
Thank you very much. Very interesting presentation, Dr. Sparks. I might start the questioning by reflecting on the fact that you have talked about several different research designs, prospective cohort studies, nested case control studies, match cohort studies, the prospective registry, and then just a little bit on randomized trials. You've included all of these designs in the work that you've talked about with us today. Could you say a little bit about why you chose one of these for this question and a different one for that question? And that's one question. Another might be, how do you decide on the sequencing? When we all went through our basic epi training, we learned, well, we use case control studies early, and then we moved to cohort studies, and then we moved to randomized trials, perhaps. But you're using all of these not in a clear sort of linear sequence. And so I just wondered if you'd speak a little bit to both of those points.
Well, absolutely. I'll acknowledge at the beginning that there is certainly some serendipity related to this as far as what's been done before me and what's available. So I certainly didn't create these data sets out of scratch. So we did kind of know the lay of the land, prior to understanding where the respiratory burden might follow. So I'd say right off the bat that, you think about both ethical and feasibility considerations, in particular related to smoking. And when you're looking at, diseases as exposures, that, both of those types of exposures are really not going to be amenable to clinical trials. Certainly, you could think about some innovative ways to maybe think about smoking cessation trials, or, um, you know, recruiting patients who only have COPD to see whether there's particular subtypes. But I think from a public health standpoint, you really just want to know whether smoking is or is not related to rheumatoid arthritis, and it's just not going to be amenable to do in a trial. And similarly, when you're trying to understand whether disease, yes or no, might be related to future risk of RA, that's just not going to be something you could randomize patients to. So I think the prospective cohort studies, have their place and trying to understand relationships where a trial is either unethical or infeasible. Related to the case control studies, in a way, it's a bit similar in that the opportunity to do blood studies and blood prior to RA diagnosis sort of has inherent strengths as far as, again, you've constructed the timeline. At this time, the blood was taken, they don't have RA, and then years later, they do have RA. So it kind of is an opportunity to sort of understand what's going on in the circulating blood prior to RA. And certainly you could think about ways to do that within a trial or to do it prospectively. But many of the strengths are going to outweigh the limitations, particularly just from a feasibility standpoint. But the point's well taken that the hierarchy of study design is probably unchanged despite the order we do them. But if we can gain new information, even if it's at a case control study, I think it's still worth doing.
Certainly the point about, you can't randomize people to smoke or randomize people to have COPD, that's absolutely the case, and observational studies are the only way that we can go forward. One of the challenges in with a condition like rheumatoid arthritis and in designs like Cohort and nested case control, you're often defining cases on the basis of a diagnosis, but you're talking about a condition that takes a long time to develop.
Mm-hmm.
And so it may be that things that you're measuring as exposures, before the formal diagnosis, are actually being measured after the disease process is underway. Just hasn't been detected yet. How far, and especially when you're collecting data every 6 months or every 2 years, do you in the analysis use exposures measured way back at baseline, which might have been years before, or are you including exposures measured 6 months before the diagnosis, which are at greater risk to having been measured after the disease process is underway? How do you think through those kinds of things?
Oh, that's actually a great point, and something I debated about including in the presentation. I think the point you're getting at is called reverse causation, where basically you think you're measuring an exposure as a predictor for a future event, when in fact early manifestations of the future event are affecting the exposure status. And you're absolutely correct in that if you can separate the exposure assessment and the outcome assessment, it protects against that reverse causation bias. So an example that we recently did was related to physical activity. So obviously this is a joint disease. This is gonna, patients the day before they see the doctor, have RA and they're limited in their ambulation. So physical activity was a particular exposure that we were quite concerned would be susceptible to that reverse causation bias. And just like you said, we wanted to try to separate the exposure status and the outcome status. So in our nurses' health study, again, we do have the luxury of having many different time points where exposures were measured. And just like you said, one of the first analyses we might do is, does baseline only predict future RA? And then we'll also put in I guess, a buffer in between, even within baseline. Let's just say we want to make sure that there's 10 years between when between the exposure and when the outcome was assessed. And we're able to actually sort of have a sliding ruler to see whether that occurs. But I think you can always make that argument, and this is one of the things that makes genetics particularly compelling, in that that's at the very beginning, at least from germline genetics. And again, we are able to incorporate genetics into our analyses given that we have biologic samples, but the point's well taken that in observational studies, you always have to be skeptical even of your own analyses, that there some biases can creep in, particular one that we think about a lot.
We have a question from the audience interested in gender differences.
Mm-hmm.
You noted very early that women are more likely to develop RA. I remember in a later slide that male sex was a risk factor for certain kinds of outcomes. From some of that, it looks like you looked at male-female differences, probably, though we didn't see a lot in the presentation. What did you see in terms of differences between men and women in the sort of outcomes that you've looked at?
That's a really good point. So I mentioned the nurses' health study are only composed of women. So we're not really able to look at directly at sex differences in the nurses' health studies. There are some similar cohorts that were composed of men, in particular the health professionals follow-up study. And it was a strategic choice just based on what the expected number of RA outcomes was, that whether the NIH would fund that or not, that we decided that we really put most of our resources into identifying cases within the female cohort, because it would have enough outcomes to support our analyses. But we're not able to directly look at sex differences in the nurses' health studies. However, because this cohort has many female-specific variables, some of our other studies have looked at female-specific variables, things like early menarche, menopause, reproductive factors such as breastfeeding duration, parity. So we are, again, I didn't put all the whole bibliography, but we have delved into many types of variables related to female health, and we do see associations. In particular, probably the one that's most striking is menopause. So while we can't directly see why or why not this is more common in women, we do see that there's some distinctions related to those types of variables. Within BRAS, again, just for sake of time, I did not show this, but you're absolutely correct that the men are a bit more likely to develop RA-ILD. And from what I know, it's not really understood why. Of course, it's thought that men are heavier smokers, but we really do the best we can to try to collect the smoking variables such that we're able to adjust for those effects. We actually do still see that men are more likely to have RA-ILD compared to women, even when accounting for smoking. The ILD is, we only had less than 100 cases, so we're a bit limited to really understand the nuances of that. But I think it's a good point that there's a lot more to understand and unravel. And I think this has broader implications because many autoimmune diseases are much more common in women. So I think disentangling and understanding that sex differences is going to have broad implications even beyond RA. We're very interested in that.
I have a question about the randomized trial. I know you didn't spend a great deal of time on it, but if I'm remembering the slide showing the design, participants were on the study drug for a year, one drug or another, and then they were off the drug for 2 years during follow-up. I'm used to doing trials where I deliver the intervention and it just stays. I don't remove it. Of course, I often work with lifestyle factors where I'm trying to get people to quit smoking, and I just keep the intervention going. In this case, tell us a little bit about the thinking that went into the decision to deliver the drug for a year and then remove the drug during the follow-up period.
Sure. Well, I have to say this was quite a discussion, and I think a lot of this was practicality and feasibility. And I'll mention this is an NIH-funded study, so the NIH was at the table, and we all came to a consensus. And again, there's an ideal, and there's a realistic, and there's practicality, and I think clinically, from a practical standpoint, clinically, patients for preventative purposes, I think this is a whole different discussion, but when you're prescribing a medication for as a prophylactic, the adherence is relatively poor, as you probably know. So we felt that 1 year on study drug would kind of more mirror what the typical clinical care would be for these patients. Having said that, if there is a true effect, the more idealistically way you can intervene that would be to have patients on it the entire time. So I think it was just always a balance between practicality and feasibility and idealism.
All right. And the two arrows that we see in this slide, is this two arms where there are two different drugs? No, I'm sorry. One is an active drug and one is placebo. Got it. Okay. Sorry.
And obviously, it's all double-blind, randomized.
Yeah.
So we're not sure which they're assigned to.
Yeah. Now that struggle between continuing the drug or taking it off, I'm sure that was a lively discussion.
Sure.
I wasn't criticizing the decision. I was just trying to help our listeners understand the reasoning.
I agree. I think if you really wanted to see whether there was effect or not, you would keep them on the entire time.
Yeah. So you've got these two large cohorts in the nurses study. You've got all of these observational projects going on where you're trying to identify risk factors or targets for perhaps for trials that you might do later. What else is coming down the road? What else are you seeing from the observational work that is helping you identify potential targets that might be evaluated in trials?
Well, I think, as I hope I hinted at, that there's kind of two phases of the RA disease course that I'm particularly interested in. One is, just primary prevention of RA. And obviously, it's a big effort to get an RCT in because it's a rare event and you have to, we're trying to find these ACPA positive individuals. So I think depending on the results of Stop RA and other studies, we've at least set up the infrastructure where we are able to recruit across the country these patients with ACPA positivity without RA. And thinking about lifestyle interventions, thinking about smoking cessation, thinking about weight loss strategies. So there's things on the lifestyle side that I think would be amenable even for a trial. But I think a lot of those might need to be in patients who are really susceptible. And again, I think we built the infrastructure to do that. The second would be among patients that have RA. As I've already illustrated, these patients are at very high risk of developing both RA-ILD as well as respiratory mortality. And they seem to have an overlap between this interstitial lung disease and airways disease. So there's, when they're already patients, in a way, I think there's less issues as far as thinking about drug interventions, and we're having a lot of targeted therapies now for rheumatoid arthritis. So I think a real bona fide, a DMARD for respiratory outcomes to see whether we could prevent progression to RA-ILD is really on the horizon. So I think it's probably going to be more amenable to pharmacologic trials within patients that have RA.
Right. Very, very interesting work, and thank you very much for the presentation today. I'm glad that NIH has been of help in funding the work. Do you have any advice for us as an agency?
Well, you build this track record, and there's more to do, and I'm hoping to add more grants to the portfolio and to continue our work.
So you would not want us to turn off the faucet in terms of...
Oh, that'd be great. I think more faucet, the better.
Yeah, okay. Well, thank you very much. I will turn things back over to Marie, who will wrap us up for the day.
Thank you, Dr. Murray, and thank you to everyone who participated in today's webinar. As I mentioned at the beginning of the webinar, we will be posting the slides and a recording of today's session on our website next week. You will receive an email with a link to the recording when it is available. Thank you.